Okay, good evening everyone. So thanks again for this invitation. We are going to talk about liver-directed therapy in incurable, but finally also incurable metastatic colorectal cancer. When and how? Here are my potential conflicts. What we have to know first is that with basic epidemiology of colorectal cancer, if you got 100 patients with this colorectal cancer, 60 will develop liver mets, and out of these 60, probably 9 will be resectable and 51 will not be resectable and will go to systemic therapy with chemotherapy and targeted agents. So it means that there are not so many patients that are resectable, and if you go through this resectable population, if you are very optimistic and say that 25% of the patients are resectable and 50% of them will be cured in long-term assessments, you have at the end 12% of cure. If you are pessimistic and you said that 15% are resectable and only 25% of them will be cured at long term, which is probably more close to the reality, you have only 4% of the entire population that goes for cure. So probably that we have a lot to do there, of course, by doing something pre and after chemotherapy, and this was really showed by the previous talks, but also maybe in trying to put more patients in this strategy of resection, and I think that here the liver-directed therapy may help to improve this percentage at the end. And beyond resection, of course, you also have to think about this liver-directed therapy to allow a new treatment line and prolong survival. This is really where they are used currently today in really expert centers. You have to also use them to decrease some liver-related symptoms in very individual cases, and to allow chemotherapy holiday as a consolidation treatment also for some patients. So why developing intra-arterial therapy? Because the double blood flow that you got in the liver really allows you in good security condition for your patient to use the intra-arterial way. That also the arterial blood flow is really the one going to the metastatic lesion, and that it allows you to really increase the concentration of your antineoplastic chemotherapeutic agents, for example. And the arterial infusion also targets directly the hyperarterial metastatic lesion for microbeads or spheres that are loaded with radio elements or chemotherapy. So what do we have in colorectal cancer as compared, for example, for HCC or neuroendocrine tumor? We got intra-arterial chemotherapy, we got drug-eluting beads loaded with irinotecan, also called DEBIRI, and we got the radioembolization with yttrium-90, and you've seen the SIRFLOX data recently here. If we go back to the old algorithm of the colorectal cancer patient with this unresectable, resectable, and potentially resectable patient, where can we put today intra-arterial therapy? Theoretically, we can put there absolutely everywhere. In fact, the orange ones shows you where it has been developed with randomized results. We will see that these randomized trials are very small trials, and we still need to be better and to have larger trials with a level of proof that need to be increased. But theoretically, you can even think about doing something intra-arterially in this resectable patient or after the resection, and you can also do it as a consolidation treatment. You can do it if your first-line therapy is not enough to go to surgery, and you have, I think, to think about intra-arterial therapy of a first-line systemic therapy that is not reaching the goal that you had for your patient initially. And of course, you can do it as salvage therapy when you don't have other option, and when the liver disease is really the predominant one, or the liver disease is still limited. What do we have currently? We have the SIRFLOX trial here in first line that was presented here in ASCO. We have the CISFER trial, which is a small randomized trial with also CIRTEX and CISFER, and the DEBIRI trial with Fiorentini that is randomized. The PASHA trial is a mistake, it's not here. So for intra-arterial chemotherapy, the idea is really to put a catheter inside the artery. You can do it by your surgeon, make your surgeon do that, or you can use your interventional radiologist more and more often today. We have, it's an old story. You can see here that publications from the 80s and 90s were already on that topic. This is with fluoropyrimidine, intra-arterial palliative chemotherapy, and you can see that it really increases in this meta-analytic group from the Cochrane group the response rate without any doubt, but it's, even if there is a trend, it's not significant for overall survival. However, this is really old trials with only fluoropyrimidine, so if we want to move to something a little bit more modern, we will go to see the American and the French experience. So the American of the Memorial Sloan Kettering Center did something still with the old FUDR, which to my opinion had some limitation because especially of his biliary toxicity, but with modern drugs such as oxaliplatin and irinotecan that were given IV in this trial. And you can see here that there is a real conversion to resection in these 55 patients, with a response rate of more than 90% and almost 40% of the patients with secondary resection. And you can see here on the waterfall plot that almost all the patients were at least controlled, and most of them were really with a RECIST response correct. Here you got, okay, the one with previously treated by chemotherapy and the one not previously, and as usually it's better to use this kind of treatment for efficacy, at least in first line, because previously treated patients have more resistance to chemotherapy, even intra-arterially probably. The second one is a French experience from Gustave Roussy. This is even more modern. It's oxaliplatin that is infused in the hepatic artery with 5-FU and cetuximab given systemically. And here you can see in this phase 2 trial with 35 patients that here again the waterfall plot shows a very high response rate. Only one patient is really progressing. 3 to 4 patients are stable. And when going to the RAS and BRAF wild-type patients, because there is cetuximab in this trial, you reach a 96% response rate, 100% of disease control rate, and 66% of secondary surgery, which is really impressive, even if in liver-limited disease patient. What you can see here also is that PFS is very good, around 30 months, and that OS was not reached in this trial. If we move to the second option, the DEBIRI, we got a lot of cohorts showing that there is an efficacy, and we got only one small phase 3 randomized trial with 74 patients only, 36 and 38, treated by DEBIRI or FOLFIRI respectively. The objective was to increase overall survival. Sorry for the curves, they are not really like that. And you can see here on the table that they made the overall survival in days, moving from 482 days to 690 days, that the response rate was dramatically increased by the use of DEBIRI. You also have to know that in this trial, some patients treated with FOLFIRI as control were already treated by FOLFIRI previously with a potential resistance to this drug, but whatever. And PFS is also increased. And what we can see also interestingly here is that really acute toxicity is for DEBIRI and late toxicity is more for FOLFIRI, and that quality of life improves. I won't go in the pharmacoeconomic assessment because I think really these pharmacoeconomic data are really depending on each country, and it's quite difficult to extrapolate them for all of us. And here you got the tolerability profile, so it's really clear that DEBIRI may be toxic in some patients, and you have really to train and to do it well, not to infuse the product too fast, probably to treat one lobe and the other if you want the maximum of secondary condition, even if the whole liver can be done in once. And you can see here that really the post-embolization syndrome is quite frequent with severe toxicity in this number of cases, and that at the contrary, the systemic treatment really more induces classical diarrhea, GI, and let's say hematological toxicities. Another point is that complete response with DEBIRI is probably more important. We have very recently reported a case of patients enrolled in a first-line trial with FOLFOX and DEBIRI, which was finally resected after 3 months of 7 liver mets, and he had 7 pathological complete response in all the mets, which is quite rare. We have complete pathological response possible in colorectal cancer, but 7 out of 7 is quite rare. And we know that this pathological complete response is important, and we already had this information previously. In the Paragon trial, you can see here in the histogram that the red ones are with DEBIRI, and that you have more red on the major and complete response than with systemic chemotherapy in blue. If we move finally to the last possibility, the radioembolization, initially we had only this small phase 3 trial, once again, from Alain and Litz, and you can see here that unresectable liver mets from a colorectal origin, PS02 chemorefractory patients were randomized to receive 5FU or 5FU and CSFR. It's really a rescue treatment, a salvage therapy if you want, and what you can see here in the table is that time to progression and time to liver progression was really improved by CSFR in this small randomized controlled trial. So we can use radioembolization as a salvage treatment since a few years, and now this has been evaluated, this approach has been evaluated in first line with the SIRFLOX trial, which is really the first large randomized controlled trial testing this intra-arterial approach in a sufficient number of patients in order to see something on progression-free survival. Patients were not resectable from their liver lesion. They have liver-dominant or liver-only disease, which is not exactly the same, and it was a stratification factor, good performance status, and no prior treatment. So it's a very pure population. It's a well-designed and conducted trial. Even if it's technically difficult to initiate this treatment at the beginning, it's feasible, and we participate to that trial with many other centers all over the world. Unfortunately, as you know, the primary objective is not reached with a PFS which is exactly the same between the two arms of 2.2 and 10.2 and 10.7 months in FOLFOX and FOLFOX plus CSFR respectively. And what is quite surprising is that really the control on the liver is here, because we are moving from the progression-free specifically in the liver from 12.6 to 20.5 months. It's almost 8 months difference in progression to the liver, with curves that are still separated at the end and long-lasting, even if you have a few patients exposed to the risk at that moment. But really, it seems impressive, and currently we don't know exactly why this does not translate in all PFS. Maybe the progression of extrahepatic lesion, and we really need now to have more complete analysis to understand what will happen in the future. As Bernard showed already, the response rate were also increased by the use of CSFR, but this does not translate in more resection at the end. And we have seen from the Bernard's talk that when you got a 60% of response, you got a 15% of resection. So it's not so easy. It's not because you increase the response of 10% that, of course, you increase resection of 10%. To use CSFR was also a bit more toxic, and especially we observed in the SIRFLOX trial a little bit more of hematological toxicities. And what is very important, because you know that we have experienced in the last year some trials with no movement in PFS, and finally a difference quite impressive in overall survival, not to name there like PEAK or FIRE-3. Maybe at the end something will happen in overall survival, and I'm really, for me, impatient for my case personally to see what will happen when SIRFLOX will be pulled with the Foxfire UK trial and the Foxfire Global trial to have the 1,100 patients needed to analyze with a good power the overall survival with radioembolization. So to conclude, really intra-arterial therapy are developing slowly, but they are developing. It's a new tool to fight liver mets. I think that they are able to control, all of the techniques are able to control the disease in the liver, and we got enough data to say that it's an efficient anti-cancer treatment. But to my opinion, you really have to think about that, and at a moment or at another time point, you have to think about that for your liver only or liver really dominant patients. However, of course, the quality of the current trials remains insufficient. Conversion of local control to PFS or OS benefit remains to be formally demonstrated in future trial, and strategic questions are essential to use them at the good time point. So I think we really need new randomized controlled trial in that setting, and especially testing intra-arterial chemotherapy. As you see, there is no randomized controlled trial to date with the modern approach of intra-arterial oxaliplatin. And currently, many trials are developing concerning intra-arterial treatment. There is, for example, on the left of the slide, the PASHA trial, which will try adjuvantly in patients resected of 4 metastases or more to treat them with oxaliplatin in the liver as an adjuvant therapy to increase the long-lasting remission in this patient. There is the DEBIRI trials in the US, in France, and in other countries, testing DEBIRI frontline with systemic chemotherapy, generally FOLFOX, plus or minus BEV. There are, of course, Foxfire and Foxfire Global coming, SIRSTEP, and many other, and we are also launching in France a randomized trial with oxaliplatin intra-arterially or intravenously in liver only in first line. I thank you for your attention and will answer your questions.